back to your table when you're ready. But we're going to get started for those who are seated.
Great. Ooh, it got quiet really fast. Well, good morning. This is your chance where y'all say good morning again, unless you have trail mix. Good morning. All right, great to see everyone. Hello virtually. I think my mom and my sister are on. They're my support system. I was talking with dear Lena earlier, and I want to share with you that my name's Tamara Jones, and I'm a caretaker. This session is supported by Estes Audiology. So we want to give them a shout out for the support for this session. And also I work for HEB, so I'm part sponsor with today. So I want to thank HEB for supporting today's event. And thanks for so many of y'all for attending. Okay, so our next session is called What's Happening to My Body? The changes we never talk about. We're going to talk about it today. This session will explore the often unspoken physical challenges and struggles women face while aging. Our moderator today is AGE's Chief Program Officer, Annette Juba, who will be the guide to this incredibly important conversation. Please join me in welcoming Annette, who will introduce our panelists.
Tamara, appreciate it. Well, thank you all very much for being here. I think I've worked in the aging and caregiving field my entire career. And I think talking about aging can be a really, really tricky thing. Some conversations like the one that we had before are really rich and insightful and eye-opening, and that's fantastic. Sometimes conversations around aging, particularly ones that I tend to have with my friends, can be pretty dismissive. I don't know if you guys are like me, but I'll sit around with my girlfriends at book club, and we quickly evolve into, oh my gosh, and this thing is happening, and can you believe this, and what do you do to combat that? And then we sort of chuckle it off and say, oh, we are getting so old. I'm guessing from the laughter that maybe some of y'all have had those same sorts of conversations. I think at the very least, whether they are rich and insightful, whether they're sort of nervous conversations, conversations about aging can make us a little squirmy. Aging is not a thing that we tend to talk about openly and positively. So for this session, we have brought in 3 medical professionals to help us demystify some of the perplexing things that go on around aging. I'd like to introduce our 3 panelists. We have Kimia Carden, a physical therapist with us. We also have Dr. Barbara Bergen, who's a retired orthopedic surgeon, and Dr. Shannon, hope I say this right, Abikaled. Close? Perfect, thank you. Who is a gynecologist, who are gonna walk us through some of the changes around aging. And I'd like to start out by having each of you just give us a little introduction to you and your expertise and what brought you here, and then we'll launch into questions.
Hi, I'm Kimia, but you guys can call me Kimmy. I am a pelvic floor physical therapist at Origin Physical Therapy, just like 10 minutes up the road. And we specialize in bowel, bladder, and sexual dysfunction for men, women, children, all people. And I have been working in this field for almost 2 years. I graduated from PT school about 2 years ago from Northwestern in Chicago.
I'm Barbara Bergen. I'm a retired orthopedic surgeon as of a couple of months ago, and an amazing process. And especially after 36 years of practicing orthopedic surgery here in Austin, I started a group called Texas Orthopedics, and it went from just a couple of us to about 37, 38 docs. I'm a mom. I have a couple of grown kids, and my husband's also a physician. I'm trying to figure out retired life, but sometimes sitting around and watching old episodes of Outlander feels pretty good and is releasing some endorphins, except when there's torture.
Morning. My name is Shannon Abikaled, and I'm a gynecologist in Westlake. And I am here thanks to Ms. Green, and thank you so much for inviting me, because one of my passions is taking care of women. And I went into my field of OB/GYN originally because I never wanted to see a male patient ever again. and that I really enjoy taking care of women at all aspects and times of our lives. Speaking from your prior session that you had in 2020, I stopped doing OB work and delivering babies, much to, I had several crying patients, but just one of the best advices that I have ever been given is do what you're passionate about at a more sustainable rate. And at some point in our lives, you know, we can't do everything and we have to make some choices. And so my choice was to stop doing obstetrics and continue taking care of women. And gynecology is something that I love doing. So I am a gynecologist only. I take care of my young little Westlake High School girls, introduce them to the world of gynecology and what they're up against. So we have that aspect of our clinic. And then I just really concentrate on taking care of women that have finished having children. I do a lot of menopause and postmenopausal work, and I do a lot of surgery. So
Thank you. And you talked about making choices in your professional life. And I know for each of you, this was a choice that you made to say no to something else in order to say yes to this. So we do really appreciate that. So Shannon, let's jump into maybe the squirmiest topic around aging. And let's talk about menopause. Does it really ever end? And if it does, what does it mean to be postmenopausal?
First of all, there was a comment made at your last session that said we're in developmental phases, and we really need to reframe menopause. It is a developmental phase and not a death sentence. So all of us, I go to that same book club that talk about how terrible menopause is. And one thing that we really need to remember is that as a cohort, menopausal women are vulnerable. We are a vulnerable group of women with an extremely large expendable income. So you are vulnerable to people saying, oh, well, let me tell you how to get through this, and you pay me a lot of money to do that. So that is kind of my philosophy and soapbox, is that I have a little diagram that I show people, and it kind of looks like your hormone status for your whole life. And when we're born over here at age 0, we really don't have any hormones on board, right? So from age 0 to 12, or whenever we go through puberty, we don't have any estrogen, progesterone, or testosterone. And all of us think that our children are just fine that way. We're not giving our children hormones at that age. And then we go through puberty. If anyone has any teenage daughters, I'm sorry. But our society gives us a lot of permission to be a teenager. Oh, she's just a teenager. And this goes on for years, like from age 10 to 17. I have a 19-year-old. Oh, she's just a teenager. She's growing. I'm like, okay. But then we get up on our reproductive hormone level, and we're there, depending on menopause, for 30 to 40 years. And all of us have figured out, how do we eat? How do we exercise? How do we live in this hormonal range? And then we hit around average age is 51, menopause. It's just the opposite side of this curve, but it's not a straight curve. You get normal, and then you go down, you get normal and go down. And that can range, that time, the perimenopausal part can range between 1 year and 5 years. That's kind of the normal bell curve of that. And then we're out here. And I have news for you, ladies. If you're healthy and you're 60, you're supposed to live to be 89. It's a long time, this part right here. So this is not normal. This is like a developmental stage, and we're supposed to live in this stage for a long time. So I am all about getting through menopause and doing that with some help for my patients using hormones to make that curve more gentle and slow. But we need to be vibrant postmenopausal women. The definition is no period for 12 consecutive months. So that's menopause. But menopause is, we need to reconstruct our book club conversations around this is a vibrant, wonderful time to be. And we live in a unprecedented time in history where we're going to live to be 89, and we want to be vibrant and living and a great contributing part of our society at all ages. So kind of menopause, it is not a death sentence, and it is a developmental stage, and we need to be wise and not let people take advantage of us. And also, as they spoke to at earlier stage, humble enough to come in and say, hey, Dr. Abby-Khalid, I need some help here. I'm not sleeping. This is terrible. I'm having these issues, and accept help. One of my biggest challenges right now is I have patients come in and they're like, I'm here and this is my problem and I've Googled how to fix it. And I'm like, why are you here? Because I can't help if you already are helping yourself. So that ability to let go and say someone else has got to help me, and I have to kind of follow their advice.
Thank you so much. So it seems to me that from what you said, we spend so much time talking about menopause. And when you think about it in the grand scheme of our lives, it's a really short time. And maybe we need more focus on this whole postmenopausal time and being vibrant and all of that in that time. Thank you so much. I appreciate that. So I think it's interesting also to find sort of synergies between panelists. And you talked about older women, perimenopausal women being, or postmenopausal women being vulnerable. Not only we talked about vulnerability in terms of emotional health, but in terms of financial pocketbooks and being vulnerable to myths about aging. And Dr. Bergen, I know that you have come up against a lot of women who come to your office to be treated for conditions that have been brought about by, I guess, from their vulnerability. And sort of trying to overcome aspects of aging. So what can you tell us about musculoskeletal changes, what we can overcome, what we can't?
You know, that's a really good question. And I think that there's a very big myth out there that everything can be fixed. And, you know, I think some of the greatest frustration, and I see it a little bit more with my female patients than I do even with the male. And that is this frustration with our bodies and the changes that our bodies are going through, and the feeling that everything can be fixed and made better, and that we can actually improve as we age. A lot of us go through our youth kind of a little more in a carefree way. We're a little more careless with our body. Then all of a sudden we get to 40 or 50 and we're like, man, I'm going to get in shape now. I'm going to do kettlebell jumping jacks. And, you know, I should be advertising for kettlebell jumping jacks. Like, yeah, that's the thing that you need to be doing, because it definitely brings people to the orthopedic surgeon's office. And CrossFit, we're like, yes, pickleball. Whoa, that's a new one. That's just made a definite increase in our business. You know, I went to a meeting. First of all, you may not know this, but there's only about 5% of practicing orthopedic surgeons who are women. And so there are not a lot of people that you will see that have experienced what you're experiencing and will have even a clue about how you feel about your musculoskeletal system. as opposed to OBGYN, where the majority are women. Although I would have to say, I when I chose orthopedics, I definitely knew you said you didn't want to see men. I knew I didn't want to see, and I didn't. So, but anyway, the myth that we can make ourselves youthful again and is out there, and we should not think in those terms. And we do live, like you have on your graph. That was really a good thing to see. Is there is a long part of our life that we will live in this aged time, and we need to protect our bodies for that period of time, our bodies as well as our minds.
Thank you so much. I think sometimes, at least what I've gotten caught up in, is that pull between protecting my body, not doing things that I shouldn't do, and wanting to be proactive so that I can be really vibrant as I age. How should people sort of weigh that? What kinds of things should they engage in to be proactive? What kinds of things do you think people should not be so concerned about?
Well, I think that we should be, first of all, a lot of how we age is mostly controlled by our genetics. I mean, you say the top three things: gene pool, gene pool, gene pool. My parents are both approaching 90. Well, my dad is 90. My mom's 88. And, you can look at your biological parents and say, this is kind of how I'm going to turn out. And, so at 68, I can look at my mom and go, well, I can look at both parents. I look more like my mom's sister now than I do my dad. So, than I do her daughter. So, we should not concern ourselves with the things that we have no control over. And I don't know if you want me to address those things now, some of the specific things that I was going to talk about.
Yeah, I think that would be great, because I know we had talked in the preparation about some of the myths and what you can overcome and what you can't. And so you've got the insight into what's reality.
All right. Well, I've got a list of specific things that we should not worry too much about. Okay. And I'm going to start from head to toe. And these are things that you are, as a female orthopedic surgeon, people come and talk to me about them. They're not going to talk to my male partners about them. When I tell them I see patients for these things, they're like, what? And so we're going to start from head to toe, and I'm going to try to run through them real quick. And a lot of times when you go to listen to an orthopedic surgeon talk, they're going to talk about the things that they can operate on, right? Your rotator cuff and your knees. And, but we're not going to talk about those things because there's no surgery for this stuff, even though people want surgery for it. So we're starting with the bat wings. And everybody, I can't tell you, and so people come and they're like, this, what about this? And they've been doing a bunch of push-ups and dips, and they've torn their rotator cuff as a result. And they're like, and I still have the bat wings. And so there is nothing you can do about bat wings. You can go have you can have plastic surgery, but you cannot build enough muscle to get rid of that bat wing. And even if you did, gravity and the loss of collagen is still going to let that stuff hang down. And so, your objective with your triceps and your biceps is to maintain yourself as you age, to maintain strength, to be able to take care of you and maybe somebody else. And that's all you should be doing. You should not hurt yourself trying to build those muscles up. All right, moving on down. Your sagging chest and the humped back. Okay, again, collagen. We've got 23 disc spaces between our vertebral bodies. They're about 7 to 10 millimeters thick. And as we age, starting about 30 to 40, we begin losing those disc spaces. You can't stop it. There's no cream that you can make it stop on your face. So there's none that can make it stop at the disc space. And we lose those. That's why we get shorter. Okay. So I don't have osteoporosis, but I've lost an inch of height. And so that's from the loss of those disc spaces. And our spine has a shape. So up here, our upper back has this curve. Okay. And so as we age, those disc spaces go away. That gets exaggerated. And we can stand up straight. You know, when I was a kid, my mom made me walk around with a book on my head just so that I would stand up straight. And I had pretty good posture for a tall girl. But most of us, as most women, when we begin to develop breasts, I don't care if they're small or big, we're ashamed of them. Hey, there's guys in the room. Get the hell out. Anyway, and so we go, you know, the guys are all walking around like this, and we're like this. I mean, we're not this. I mean, some people were, but we're just that. Okay, that creates this through our lifetime. It creates this tension and weakening of the chest muscles. So as we begin to age and that spine does this thing, then, you know, the collagen and everything, we know about all that. You can fix that with plastic surgery. But you can't fix this with any working out. People go and they do all these exercises. They do a bunch of tricep and lat exercises, and they get reverse, you know, the tables that reverse your spine, and they try to figure the way they work. But you can see that I can pull my scapula back, and I can straighten up my neck. I can correct that curve. And neither can you. And so okay, now moving on down. Y'all want me to keep going? All right, because I want you to love these parts. I want you to send positive endorphins to these parts and not negative. All right, muffin, top, love, handles, poochie belly. All right, again, think about our spine. It's shortening. And in this part of your body is where all your organs are. And remember, some of you may remember ice cream sandwiches, and we would squish them and lick the ice cream around the sides. It kind of pooched out. Okay, so that's what happens there. We lose those disc spaces, and there's less space for all the junk. And so there's less space for the skin and the fat and the muscles. And so we have these thickened areas in Poochie belly, even skinny people. And so the skinny people, they're more concerned about it than the overweight people, because they can see it more. And they're like, what do I do about this? Plastic surgery? Okay, yes, you can do it. But you can't make that go away, because it is less space for all that stuff. That stuff will not go away. Moving down. Our flat butts. You know, when I was a teenager, it was fashionable to have a flat butt and skinny lips. And so we walked around like this, you know, and right. Now, some of y'all remember that. Some of y'all are too young, but we did not want to have our butt sticking out. Now everybody wants a big butt. And they go and they do a bunch of squats and they ruin their knees. I'm anti-squat, especially as we age. But what happens there is a very fascinating. So you lose that disc space, which is trapezoidal. It's not rectangular. And I've got everybody in the back needs to see. So your sacrum then begins to come in. It actually achieves the thing that we tried to do all those years, you know. And so it actually skeletally, it flattens your butt. And then at the same time, we're losing gluteal muscle mass. And at the same time, all our collagen is sagging. And so we're getting the flatter, wider looking butt. And so that's, and you cannot stop the loss of that collagen in that disc space. You just cannot stop it. And you could build up muscle all day. You can't keep up with the loss as you age. And last, chubby knees. Okay, I got some chubby knees from both of my parents. I mean, I got the double dose of it. I haven't seen them in a pair of shorts since they were like 30. I don't know. I don't even remember. Anyway, and they're both thin people. They're in great shape and they look great. They don't wear shorts. Anyway, the chubby knees, people come to me and they want to get an MRI. They think there's a cancer in the inside of their knee. So we have this, our flesh and our fat is attached to our muscle with some fascia, and it attaches all of our skin and our fat at various places, like little stitches. If we didn't have that, when we age, we'd look like candles. Everything would be hanging around our ankles and our wrists. But we have this nice stuff there that holds everything in place. But there are places where it attaches, and around the knee is one of those places. It's right here, okay? And we have a little extra fat there because there's some important nerves. And any place that we have a nerve or a blood vessel, we got a little extra fat to protect it. So as we age, that, and genetically, some people have thinner knees, but some people have this sort of thick knee. And as we age, everything begins to sag, and it sags right there. And there isn't anything you can do about it, except you can have a plastic surgeon go in and suck the fat out. But otherwise, you can't build it up. And people obsess with it. They do squats. They hang on upside down tables, and they think they have tumors there. And so I try to convince them not to get MRIs, but people will pay cash to get an MRI of their knee and make sure there's not cancer there. So anyway, those are the things that these are normal findings. You can't exercise them away. You can't remove them. Best to cover them up. Let's have 3 cheers for the tunic, right?
Thank you very much. I think what I'm taking away from yours is no pain, no gain is one of the biggest myths there is out there. And we definitely ought to pay attention to what our body's saying. Thank you. You also talked about the fact that women don't talk about these things to male orthopedic surgeons. And Kimia, you talked about in your bio, I think you said you identified a need to open the discussion surrounding pelvic floor dysfunction and hope to make others more comfortable discussing it. So I'm curious what you have noticed in general about women's hesitation to talk about sensitive things with physical therapists, doctors, other medical and healthcare professionals.
Yeah, so like I said, as a pelvic floor therapist, we specialize in bowel, bladder, and sexual dysfunction. And some people might feel more comfortable talking about their saggy arms or the chubby knees, or might not even feel comfortable talking about those things. But even more than that is, how often do we talk about peeing, pooping, and sex? So, on average, we don't. Yeah. So on average, we happen to be like the 7th provider that a patient sees in the medical world before some of their questions are answered. And whether that be because I'm the first person to ask someone, are you having urgency, frequency, incomplete emptying of your bowels and bladder, or are you having pain with sex? How long have you been having pain with sex? So whether it be that, or just the fact that it's been taboo to talk about these things in our community because, don't talk about down there. Whatever it might be, or medical trauma, right? Like some people aren't comfortable even looking at themselves in the mirror, let alone talking about those parts with someone else. So sometimes, like I said, I might be the 7th provider that a patient sees on average, but sometimes it could take like 1 to 10 sessions overall for a patient to even fully open up to me about what might be going on before we can kind of build that rapport and trust, which just goes to say also how important is it. How often are you seeing a provider? If you're only seeing a provider, you haven't seen them in a year, then it might feel more intimidating to just show up and be like, by the way, I've been peeing my pants for the past year. So yeah, I would just say like being trauma informed has been super important for our practice, understanding verbal and nonverbal cues to be able to talk through these things with patients. And the thing that I find that has helped the most is just encouraging patients, which they'll do this on their own, to talk about this with their peers. And I feel like generational differences come into play a lot here too. Like aging happens on a spectrum, right? So we see adolescents, prepartum, during pregnancy, postpartum, and elderly, and kind of everything in between. But I would have to say like my teen patients and like pregnant patients more than ever have been talking about, and just talking to my colleagues who have been in the practice for even longer than I have. There's been a lot more like social media awareness on pelvic floor therapy and talking about how it might be common to experience these symptoms, but it doesn't have to be normal, and there is help out there, because that's what encourages other people to go and seek that care as well. Like yeah, it's okay to change your underwear a couple times a day and to use incontinence products, but you don't have to do that forever, right? And the sooner we talk about that and the sooner that that can be addressed and the sooner that you can get help, the more likely you are to get help. But regardless of if there ends up being like surgical intervention, there's still help out there for post-surgery even. So just understanding like on the spectrum of how long symptoms have been experienced and where you are in the process of what you are experiencing, there's always someone to talk to about it. And the most important thing is to talk about it, right? So you can figure out who can help you.
Super, thank you. It's encouraging to know that generations coming behind us are maybe more open to talking about these things. You talked about peeing, pooping, and sex, the three big things. And AGE has a health equipment lending program which gives out incontinence products to clients. And I know even among us who are handing these products out all day, every day, it's still uncomfortable to know how to talk about them. Are they diapers? Are they incontinence products? How do you ask somebody about what's going on? And how much do people really expect that they will need these products as they age? So what can you tell us about expectations regarding continence and incontinence with aging?
So like I mentioned, these symptoms, incontinence, whether it be urinary or fecal, common doesn't have to be normal. People will come in and be like, yeah, I mean, I have a lot of people who come in and have incontinence and don't even tell me, like I said, until a couple sessions in. Like we'll be working on their pain with sexual activity or their constipation. And then a couple sessions later, they'll be like, you mentioned, like you asked me on that first session if I pee my pants. And actually I do sometimes when I cough or sneeze or laugh, or jump on a trampoline, but I just avoid that now. Like I just don't jump on the trampoline with my kids because my mom and grandma told me that it's normal to leak.
I think Barbara would agree with that. Don't jump on trampolines, right?
No kettlebell jumping jacks. You'll be totally soaked.
Yeah, but piggybacking off of what was already said, there are hormonal changes that happen throughout our life, and there's musculoskeletal changes. And there's some things that I can't fix as a pelvic floor therapist, and there's some things that nobody can fix. But there's ways to support and ways to change your function and to reach those goals without me actually changing the structure of your ligament or the fact that there's muscular atrophy that's happening, right? Like as we age, the sphincter muscles around the urethra and the external anal sphincter, there's changes and degeneration that I can't change, but we can talk about postural changes and pressure management and other things and strengthening to a certain degree to help with the incontinence. So kind of going off of what I said before, like, yeah, it's okay to use incontinence products and whatever you might call them. Like I'll ask patients, do you wear panty liners or, pads or whatever, but okay, now what's our goal? Like, let's say in 6 months, we want to go from using 3 panty liners a day to just 1. All right, like then we reassess that and we see where we are with our goals. Not trying to change this overnight, but just talking about like that conversation of there's ways to get better and kind of working together and to come about those changes.
I would say I speak about sex a lot, and I ask every single patient, do you have pain with intercourse? Because especially postmenopausal, if everyone looks at your back of your hand, you can see our skin gets a little thinner. My skin, I can see more of my blood vessels than you can see of yours. So we're about 30 years different. So when you can see the thinning skin on the back of your hand, that's happening in your vagina. And actually, topical estrogen cream is awesome. We use it for incontinence therapy. We use it for painful intercourse. And it can be like life-changing. So there's nothing super novel or expensive or easy about our treatments. Like pelvic floor therapy is really work intensive on the part of the patient. And also remembering to put that stupid gooey vaginal cream on every other night is kind of work intensive, but the payoffs are really great. And so in that respect, there are definitely things that we can do. And speaking about it and having a healthcare professional that asks you so that you can be like, yeah, kind of hurts, so we just don't have sex anymore. You're like, well, the solution to that is have more sex. So all the husbands love me. but my job is to make it so it doesn't hurt. And that even though you might not be in the moment, you're looking at the ceiling thinking, do I need orange juice? That to normalize that, but that it doesn't hurt. So
I'm not taking my husband to the office visit with you. There are neurological causes of incontinence, and they can be very severe. Don't wait, to see somebody about that. Catching a lot of these things early is really important. And it's not, a lot of times you'll be talking to your friends, or your mom, will say, well, I had that too. It's just part of getting old. But some of these things are fixable, and you should talk to a medical professional about it.
Thank you. It's interesting how I came in with all of these questions, and you guys' answers are leading me into a whole lot of other areas that I want to explore. So Shannon, you talked about your job. So tell me a little bit more about when women should see, or how often or how long women should see gynecologists. And I asked that because after I had my kids, I quit going to my OB-GYN and I just go see my primary care doctor. So what really should women do?
Always come see me. No. I would piggyback off what Kimmy says. Having a healthcare person that you trust and have a relationship with is something our society's losing. We want to go to urgent care. We want to be seen in 5 minutes. I don't have time to have a pediatrician. I just need to dump the kids off here. I just need to drive by, get my pap smear done. So you don't address any of that, like, hey, how are you feeling this year? Or how's sex? Or any of those issues. Are you having incontinence? I examine people and say, are you having trouble going to the bathroom? Those kind of questions. So number one, I urge my patients to bring me their daughters between the age of 15 and 18, just to start a relationship in an environment that they can visualize that that's where they get their information. If you're getting your GYN information off the internet at that age, which that's what young people do, then there is no personal relationship, and you don't have anyone that is protecting you. All the millions and millions of information that's on the internet has to be filtered through someone who's been doing this for 30 years and then directed directly to that patient, to that 16-year-old. So I think that's really good. And that applies to us as older ladies, where we're going through menopause and you're seeing your primary care doctor. They have to do head to toe, and they don't have any time for this part. And they're kind of don't like it. Most of the doctors are like, whoa. My son is in med school, and I said, oh, what do you want to do? And he goes, I want to be a surgeon. I said, oh, like me? He goes, oh, no. I'm going to be a real surgeon like my dad. So anyway, building a relationship, one, is super important. And then for me, my job is to normalize it. Like, let's say we're all headed like to 289, we hope, right? We're all going to die in age. So how do we do that? And 3 things I would leave you with. One is both for our mental well-being, the only known treatment of Alzheimer's and dementia is 30 minutes of exercise every day starting in your 50s, and control of high blood pressure. So those 2 things I really put out there for my patients, and those are not really GYN things. Exercise, like I totally agree with you, Barbara, about you can cardio until the cows come home when you're 55, and you are not going to change this body. And that is my number one thing. People come in, I hate what I look like. And I'm like, you look great. So having a good BMI is important, but it's going to look a little bit different. So exercise needs, my healthiest 85-year-olds are people who walk 30 minutes every day and take no meds. So that's my goal for you. And gentle exercise. I disagree. I think a little bit of weight is good for you. So I really like those little 3 to 5 pounds weight.
The little pink ones.
Yes. So exercise and watching your high blood pressure, if you have that, are amazing. And then my job is to say, nobody checked your hormones when you were 20. And the range of normal is about this big. So nobody knows when you go through menopause, were your whole life, were you down here hanging out in the low end of normal, and you just shift to menopause and you're like, not that big a deal. Like, I don't know what my mom is complaining about. Or are you this lady over here that your whole life you have been way up there with your estrogen, testosterone, and all that, and you go through menopause and it rocks your world, and you're over here, you're like, this is the worst thing that ever happened to me. So my job is to take all my patients and say, look, you're going to need some hormone therapy for a while until your body's used to a lower hormone. Or, you know what? You don't have to do everything the ladies in the book club are doing. If you're fine and you don't want to take any hormones and you don't need hormones, you're going to be okay. But you got to exercise. You've got to do your weights. You've got to keep coming to see me. So
Thank you. And boy, my book club is going to have a much different conversation next month, aren't we? Well, this is a question for everybody. Y'all have all talked about the importance of having good relationships with your patients so that people feel comfortable bringing up these things that they might be nervous about. And yet, doctor's offices or doctor's appointments sometimes are about 10 minutes long. And it's very much a checklist of, do you have guns in the house and how much alcohol do you drink and do you walk every day? And you sort of go through the checklist and then you're done. So in that kind of healthcare environment, how can women be empowered to build a relationship and to have, time to talk about those things?
That's a really difficult question. And I don't think, sadly, there's not really a good answer for that. We are extremely short on primary care physicians. And the way that the coding through the Medicare and Medicaid, which goes over to regular insurance, they use the same methods. It now is set up so that doctors cannot really afford to spend as much time with you as they used to. They get paid more for prescribing as opposed to spending time with you and just talking. They don't get paid for their expertise. It's a very unfortunate situation. I think that with regard to primary care, I recommend that you've got to make your appointments way ahead of time. You nowadays you can't just call up and it's harder to call up and just ask for an appointment to see your primary care physician. So find a primary care physician and make your regular appointments plenty ahead of time. And when you see that doctor, if it's for your wellness visit, that's what it's for. If you've got a new problem, make another visit for that, because they don't have time to see you for every single problem. And sometimes, for specialists, I think that sometimes you don't have to go through, if you don't have an insurance that goes through your primary care physician, go directly to the specialist. I know in our group, you don't have to have, unless your insurance requires it, you don't have to have a referral. So you've got a finger that's sticking off to the side. You don't have to see your primary care doc for that. Go directly to the orthopedic surgeon. So I think a lot of it is management of your appointments and really trying to focus in on the purpose of that appointment. I mean, sadly, you just can't go and sit down and you know, have an extended visit. It's frustrating.
Thank you. Kimia, what were you thinking?
I think making the appointment and getting there is half the battle. And then I would just encourage everyone to talk to your peers, your kids, your grandkids about opening up the conversation again, like being comfortable bringing up this pain or whatever symptoms you're feeling sooner rather than later again. So yeah, just feeling comfortable talking about it so that it could be addressed as soon as possible.
Do you have anything to add about how you like patients to come in your appointments?
So if you called today, I think my next appointment's in January. That's the hard part, is that, you know, there's self-care also for us as physicians. And we just can't see everybody. But I have two things I would leave you with. One, you really have to like your provider. So just keep searching. If you just get a bad feeling, just find another gynecologist. And I have had that conversation with the patient. I'm like, I don't think we're connecting well. And it doesn't hurt my feelings that you get a second opinion or you go see someone else. Especially pelvic floor therapy, you got to like that lady. That's some. So you just have to, like, in your heart, like the person that you're seeing. And then if you do, work around their schedule, make an effort and go and see them.
Don't let someone operate on you who you can't talk and you don't like. It's amazing. And I would say women more than men will accept a doctor who they say was a total a-hole. And I'm like, and you let this person operate on you, they feel that they don't have choices. They're not comfortable saying no. And they go down this path. And I would say I probably haven't ever had a guy tell me that they let somebody operate on them that they didn't like, but I have had women, lots of women, tell me they let somebody, and then that person wouldn't talk to them after the surgery. It's a very, if you don't like that doctor, don't let them operate on you.
I think those are very wise words. I think sometimes we get caught up in well, they say person is the best. And so, you know, all the other trappings, personality, relationship, all of that doesn't matter because they're the best. And you end up sticking with that. There we go. Our book club's going to solve all these problems. Yeah. When you're talking with your friends, oh, well, you should go to this person because they're absolutely the best. And I love them. Well, just because my friend loved them doesn't necessarily mean that I'm going to love them and they're the right match for me. Well, Kimia, I want to ask, honestly, before this session, I had never heard of pelvic floor therapy. I'm not even sure I can tell you exactly what your pelvic floor is, except to use Barbara's signs. I think it's this. But so how would I know if I needed a pelvic floor therapist? Is it the kind of thing that I could just say to my doctor, I think I want to go do this? Is it the kind of thing I can just go straight and do on my own? Pelvic floor therapy 101.
Yeah. So it depends. Physical therapist regulation just depends state by state. In this state, so in Texas, you can see a pelvic floor therapist without a referral, but you can only see them for 10 days before a physician needs to sign off on your plan of care. So you can come see me right away, but you can only see me for 10 days if you don't have a referring provider. And your pelvic floor is, you have pelvic floor muscles. They act like a bowl. They extend from your hips and then from your pubic bone to your tailbone, front to back. And your pelvic floor muscles support your organs, so your bladder, uterus, and rectum. And they also support, so they have to be strong enough to support those organs and to help with pressure management, right? Like my favorite analogy is, think of your trunk like a soda can. Bottom of the soda can is your pelvic floor. Top is your diaphragm, so your primary breathing muscle, and wrapping around are your deep core and back stabilizers. So all those three parts have to work together to help aid in bowel, bladder, sexual dysfunction. So if you're having any concerns at all with anything that comes with peeing, pooping, or sex, even if you just have questions about it, I would urge you to go see a pelvic floor therapist or talk to your primary physician about it. And be like, hey, I heard about this thing called pelvic floor therapy. Do you think I could benefit from it? And even if you're unsure, we'll just do an assessment or kind of talk through things that might remind you, oh, like I do wake up 3 times in the middle of the night to pee, or, oh, I have been having pain with sex for the past 4 months or for the past 10 years. You know, whatever it may be, I just urge you to ask for help. Even if you might think it's the smallest thing, like we're trained as women to just like be strong and like get through it. You know, like, yeah, it's normal to feel this way after you deliver a baby or 5 babies or whatever it may be. But if you're feeling uneasy about something in your body, go get help for it.
Thank you. It's interesting to me, as y'all have talked about the kinds of things that women ask you about and the kinds of things that they don't ask you about, that we seem to ask about these outward trappings, the bat wings and the muffin top and the fat knees and all of that. And we don't ask about the internal things. I get up in the middle of the night to go to the bathroom. I just assume that's the way it is. But it wouldn't have crossed my mind to say to my doctor, should I be getting up every night to go to the bathroom?
Yeah. And one more thing, your pelvic floor muscles are muscles like any other muscle in your body. So I talked about the strength portion. So like the muscles have to be strong enough to support you, but the muscles can also get too tight. Like some people carry their stress in their jaw and they end up with temporomandibular joint problems, or some people carry their tension in their neck and they end up with neck pain. That's the most common thing, right? Like you look in the mirror after a stressful day and your shoulders are hiked up here and you're like, yeah, I've had a stressful day. But you never think, oh, my day has been so stressful, I can really feel myself carrying that tension in my pelvis, right? But again, muscles, just like the muscles in your neck, just like the muscles in your legs, just like the muscles in your jaw, those muscles can be affected. We just can't see them. So we don't think about them or talk about them.
Thank you so much. All right. Well, you guys have been great at answering almost all of my questions. I'm sure you can come up with more, but I'm also guessing that there are a lot in the audience and I see a bunch of hands. So Jaden, you're going to borrow a microphone and let's have a question. It doesn't matter. Whoever you're closest to. How was that?
Okay, is it on? I am asking this for a friend. I have a friend that had cancer, and so she does not take estrogen, can't use estrogen cream, that sort of thing. And she has pain with intercourse. Can pelvic floor therapy be helpful to her potentially?
So unsure unless I do an exam on her. So there's certain exam techniques that I could use to see, is there hormonal contribution to her symptoms, or is there tension contribution to her symptoms? So right off the bat, you saying that she has a history of cancer tells me that's trauma, right? That's medical trauma. So did her pelvic floor react to that cancer in a form of tension? Or were there neurologic or hormonal changes associated with that cancer that might be contributing? Regardless, she should come get checked, right? Just to see, is there someone else that I can refer her to that could better help her, or vice versa, whoever she ends up seeing.
Okay, and I've got one more thing. I just want to show y'all, you can't do anything about your bat wings, but if you ever have a short sleeve on and you need to take a picture,
Nice. Okay.
So I really wanted to ask 2 questions, and we get a lot of information on how to do a breast exam. But I was reading an article a couple weeks ago about how most women at any age can't identify the parts of their vagina. So how important is that to do a vaginal exam on yourself and be familiar with that, because it does change. And then how should you douche or not?
I don't like douching. One, it kind of changes the natural environment of the vagina. And so all our body has biomes with that's why we take probiotics with the bacteria in it, and douching will change that. So I don't really like douching. I love probiotics. I think those are really good to take. I really don't care what kind, but they have all kinds that they'll sell you. And then knowing your vagina, number one, there's argument in our literature that says don't tell people how to do breast exams because then they freak out and they're always asking, and you're getting all kinds of unnecessary tests because people are nervous. And that would apply to the vagina as well. And I'm like, yeah, but if you're not seeing the same provider for 20 years, and you got to know yourself. So one thing to do is have a good provider that tells you, this is your breast exam. I want you to go home tonight and feel your breast. And this is your normal lumpy, bumpy self. So just do that every once in a while. If you keep doing that, when you're 40, then you're like, that's not my normal self. Come on in. And you will find something before a physician does. The same thing would apply to the vagina. It's that after you see a physician that you can trust and they say, hey, this all feels and looks really normal, and go home that night and be like, oh, this is all my normal self. And that's good to do. I have one patient who one physician told her that her vagina didn't look right to him. And her whole entire life, she never, ever let anyone see her vagina. Like, I was the only one that ever saw her vagina. She had sex in the dark, and she cried the whole time she delivered her kids. So there's huge impact that we have on how people see themselves. So knowing yourself and being able to check your own vagina, great idea.
Hello. So I am a 42-year-old woman still going through fertility things. And I hired a personal trainer, and I am a 3-week patient at Texas Orthopedic right now. So that whole idea of pushing till you can't is reality. But one of the things y'all talk about is going to different doctor's appointments and going to good ones and getting those opinions. But the problem is that, I love my fertility doctor, but he says, get your BMI down. He doesn't care how, he just says, get it down. Well, do y'all have any recommendations for resources, books or websites to help kind of guide us as we're aging of like what we should be doing? Because I didn't even know a pelvic floor doctor existed. I do know a lot about orthopedics now because of the last 3 weeks. Thank you very much. But, are there resources we can start researching? Because if we're looking at a doctor that's weeks and weeks out, we don't know what we don't know. And that's the thing that I think, especially as we're starting to age and getting into that next stage of life, well, I'm so desperately still trying to have a child, like we don't know where to begin. And if y'all have any resources, I would love to hear about them, please.
That's a tough one. And if I knew the answer to that, I'd be doing it. There is so much information out there on how to lose weight and how difficult it is to lose weight. A lot of doctors really believe that overweight is a disease and should be treated as a disease with medications, surgeries, that there is a metabolic issue that really cannot be corrected long-term and satisfactorily with just diet and exercise. And guess what? I started my first diet in, probably 1970, Weight Watchers, right? And it was terrible back then. It's better now. But, so we've been telling people to diet, and now it's the catch term is improve your BMI, but that means the same thing. And we've been doing that for a long time, pretty unsuccessfully, because we're just getting bigger and bigger. And so I think, it's hard for us as medical practitioners to sit here and say what's right for you. And, so it's, and to tell you a book to read that is beneficial. I think you've got to do a little bit of exercise. I think building some muscle, and I'm in agreement with building muscle, not to the point that it hurts you, But as we age, we lose muscle mass, which is our calorie burning tissue. And each time we diet without building muscle mass, we are losing that calorie burning tissue. So an exercise program has got to include some aerobic. I don't know that that extreme aerobic exercise does what we want it to do, but some aerobics and some weightlifting.
And I always encourage people, never stop trying. It's just like smoking. Every time you try to stop smoking, then you have a better chance of stopping smoking. Every time you say, I'm going to change my diet. And I've had ladies come in and I'm like, oh my God, 30 pounds. How did you do that? I decided I had a little trampoline, and if I watched my movies with the trampoline, I jumped on the trampoline, I lost 30 pounds. I'm like, novel idea, but it worked. Some lady was hula hooping. Weight Watchers, Noon, walking, whatever it is, intermittent fasting. I intermittent fast and I never lose a single pound. So some of us can intermittent fast, drop 25 pounds. Some of us, unless you eat at 7 a.m., 10 a.m., noon, 3, and 5, and keep that sugar level at a steady state, you're not going to drop a single pound. So everybody's a little bit different. There's not one set way to do that, but don't stop searching. And that would be my message. Also, that core, the pelvic floor, that's what, as we age, that keeps our bladder healthy. And I always stand up in my clinic. I'm like, when you're about to fart in church, you hold your butt muscles together and you pull in. That's what we want. That's the core, not this stuff where you're doing crunches. So
I just hate to see some clips from this video of you and I both walking around with our.
All right, this is going to be our last question.
Mine is just a comment and a very big thank you to the panelists and to the sponsors for bringing in your expertise from a female perspective. I just wanted to share, I had a wonderful OBGYN for 30 years. He retired, but this leakage problem, he talked about it with me and he said, we have a way to counter that. And I was like, yeah. And he says, just when it starts to happen, think of something else. And so the first time I tried it, and then I was like, I wonder what I was supposed to be thinking of that would, because it didn't work. So thank you for addressing it, that it is definitely an issue.
All right. Well, thank you all very much. I learned a ton. My book club will learn a ton next month. I think I'm going to go home and get rid of the green weights and keep the pink weights. And, go ahead.
Quick comment. And I don't know if I imparted this to you well enough. Do not hurt yourself doing an exercise. Do not work through a painful exercise. And lastly, I have a medical self-help blog, drbarbarabergen.com, and all this stuff is in there. You can check it out.
Thank you all very much. I hope you all feel empowered to go talk to your doctors.
All right. Thank you guys so much. We appreciate it. So we're about to eat. So I hope you're excited. I am. Just a couple of housekeeping things. One, as just a last message, she's not looking up right now, but I wanted to point out that my mom is here at the back of the room. And so what's great is we're here at this conversation together, and now she can support me as I age, and I can support her in making sure that we're doing what we need to do medically. And so I encourage all of you to share what you've learned today with your daughters, your sisters, your nieces, so that way they benefit from this wonderful expertise as well. All right, so moving into brunch, we have brunch set up at the back of the room. It's buffet style, so we're going to be ladies who brunch for a little bit. Excited to share that we have Dr. Robert Whitfield joining us at noon to do a little bit of a talk around the issue of food sensitivity as we age. So we're going to get to benefit a little bit from his expertise as well. So if you guys want to go start forming a line at the back of the room, then we'll get the buffet started. And at noon, we'll start the noon session.